Just wanted to remind you we're going to take questions at the end, so people can jump in. But thank you, Don. That was really great, and I hope it opened up the discussion for what we, or the ideas for what we want to talk about in our session. And I'm going to switch a little bit over to how we actually talk about decisions when there's uncertainty about our options that we present to patients. And patients are often coming in these emotional states and sometimes getting a diagnosis, sometimes having had a diagnosis with lots of complex thoughts going on. And then when there are situations that involve uncertainty, there has to be some sort of dynamic and discussion about how to actually cope with some of these and cognitively and make a decision with all of that uncertainty and unknown going on. So hopefully at the end of this shorter session of the larger group, you'll learn about some of the steps in shared decision making, and then Tony Bach will be talking about how to respond to emotion during these processes. I wanted to bring up this model of patient-centered care. A lot of people, when I start talking about shared decision-making, ask, how is it similar or different from what we're already doing? A lot of people, I'm imagining in this room, practice patient-centered communication and talk about how to actually work with your treatment options from the patient's perspective. And shared decision-making takes this a step further and really breaks apart a step-by-step process of managing uncertainty, making decisions, and exchanging information to facilitate that process. And it's very similar to some of these other components of patient-centered care, but really focusing on the decision-making during uncertainty. So shared decision-making is often defined as this process by which decisions are made collaboratively by doctors and patients, informed by the best evidence, so it's evidence-based, but weighted according to specific characteristics and values of patients. We don't normally just make recommendations because most of what we do in medicine, and especially oncology, is uncertain. This is a figure that's published by the BMJ's Clinical Effectiveness Series, and they summarize the effectiveness of over 3,000 treatments studied in randomized controlled trials. And 50% of those treatments overall, not just in oncology, are of unknown effectiveness. We really can't say which one may work for specific patients. And then there's this additional 7%, the purple pie, part of the pie, where there's a trade-off between benefits and harms. And this is something that's really hard for patients to grapple with. We wish we could tell patients this treatment will work with no side effects or no, this is the perfect cure with nothing bad that comes about. But we're always asking people to make trade-offs. Even in the situations in this graph that are likely to be beneficial, that's on a population level, and we don't know which patients will benefit and which patients may not, and under which circumstances. So there's a lot of uncertainty. And when there is uncertainty and patients aren't and clinicians don't discuss this with patients, it can really affect the relationship and trust. So this is a patient from one of my studies who was 64 years old, and she had an abnormal mammogram. And her OBGYN was not that worried, but recommended a biopsy or repeating the mammogram in 6 months. But she referred the patient to a breast surgeon just to talk further to get a more specialized opinion. And the breast surgeon looked at the mammogram and just said, we can just repeat this in 6 months, and didn't really discuss the possibility of a biopsy. And the patient was really upset, and afterwards she told me, I'm going to biopsy. My other doctor told me that, so I know it's an option. I don't want to wait. I've known 2 older women who waited 6 months and should not have. Sometimes they tell older women to wait, and I think that's wrong. And this was something that the surgeon didn't think was a big deal and just thought, this doesn't look that scary, thought it was reassuring to just repeat the mammogram, and it really affected the relationship, and I believe she went elsewhere, actually, over this decision. So not acknowledging this to patients can be problematic. So the first step in shared decision-making is identifying which are the situations where it's really critical to engage in shared decision-making. And this is not as straightforward as it seems. So these are the NCCN categories of evidence and consensus. If we start with category 3, where the recommendation is based on any level of evidence but has some major disagreement, most people would say shared decision-making is appropriate. We need to discuss these options. There isn't really agreement. Category 2B, the recommendation is based on lower level evidence, and there's non-uniform consensus but no major disagreement. Probably need to discuss this with the patient as well. But a lot of people say, well, what about categories 1 and 2A? There's high level evidence, there's uniform consensus, or maybe lower level evidence, but we agree. But there are still some patients where they may have comorbidities, they may have increased toxicities for their specific situation, they may have strong preferences against one or another option, where no matter what you say, they wouldn't necessarily follow the steps involved in one option. And so those situations can still involve shared decision-making, may still be appropriate in those contexts. So once you identify the situations, acknowledging it to a patient, which again seems somewhat straightforward. But in one of my studies that I did actually with Don, the criteria for referring patients to the study was that there was uncertainty that they would be discussing during the visit. So there was some treatment option that needed to be discussed. And 5% of the time, they didn't actually acknowledge this to the patient. They went in and thought a priori, oh, I think this is where she's leaning, so let's just talk about this one option. So using plain language is important, listing options clearly when you're talking about them, and allowing the patient time to process the information, even if this is just a few minutes. As Don described, people are dealing with so many other things. They don't always hear what you're saying when they're processing a lot of these emotional responses. They may be hearing, I'm going to die. They may be hearing cancer, 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 and nothing else. And something that I found really effective is if you can actually leave the room and see a patient that's there for a quick follow-up and tell the patient to give them time to get dressed, get out a pen and paper, think about it for a minute, gather their thoughts, especially if they've just received a diagnosis. That can really help. They don't mind waiting if they're sitting there ready to hear complex information. And inviting family members who may be in the waiting room or maybe even haven't shown up because the patient didn't know that you're discussing complicated treatment options. Sometimes they want to call someone on the phone and put it on speakerphone just so there's somebody else that's listening. Allowing them time to do that can be really helpful. Here's one of the newly diagnosed breast cancer patients from our study that said, I wish they told me the news in a more comfortable room. I thought I was going to be told I had a cyst. I was shocked. I didn't have a pen or paper. My feet were dangling off the exam table, and I would have at least preferred to be sitting down near my purse fully dressed. And she was really vocal with me afterwards. She said, just being undressed was really, it made me feel so vulnerable. And if I were dressed, I would have had this one-on-one conversation that could have been much more open and communicative, and I think I would have heard the information in a clearer way. Another thing people always ask me is, what if my patients don't want this model? People may not want to make the decision together jointly. They just want me to tell them this is the best for you. And that may be true in some situations, but a lot of times studies have shown that patients really do want this information. They just don't always know how much uncertainty is present. So they may say, make the decision because they think there is a one best answer. But once they see something like a patient decision aid or they go through the information in a little bit of depth, then they say, well, yes, of course, I want my preferences heard, and I may choose one or the other because there's no best option overall. And it really does matter what I prefer, what my opinions may be. And so they may then say, yes, I'd like you to make the final decision, but I'd like to be involved in it. So assessing their role preference after at least describing the decision in a simplified way is really helpful rather than a priori going into the room and thinking this patient may not want to engage. I'm just going to tell them what we're going to embark on. So the next step is then describing the options in more detail, including uncertainty. And I heard someone in the room earlier saying, as Don was talking about how, yes, the statistics are really hard for people to understand. They don't always hear that. So I'm going to go through some steps that help people better understand statistics. So this is sort of the overview in case you want to see them all together. So presenting data using frequencies, using absolute risks instead of relative risks, and using pictographs if you use graphs. These are what have consistently been shown in the data to be most helpful for patients understanding risk information. And starting with what is most important and then adding some detail later if patients want more can be helpful. So here's an example of using frequencies with pictographs. This was actually a study done out of University of Michigan that compared Adjuvant Online, which is an online tool where you can calculate people's risk-benefit information from adding chemotherapy, and they presented it using pictographs instead of the bar graphs. And they said the graph below may help you decide if adding chemotherapy is worth the side effects and risks that chemotherapy could cause. And they have some shaded boxes out of 100, and they use different colors, and they describe what those colors represent. The only thing we do slightly differently now is we try to avoid red and green if people may be red and green colorblind. But they were trying to make it as close as possible to the output, just in a different format. And people really prefer this and can understand this more clearly. It's a little bit easier to understand visually and see the risk-benefit information. And they actually do the math for people where they calculate incremental benefit as well, rather than making people add and subtract. Another study out of the same group actually compared bar graphs, pie graphs, and pictographs, and found that pictographs outperformed bar graphs and pie charts. Overall, people had better gist recall, meaning they understood the overall information. They also had better verbatim recall of the risk number, and they interpreted them pretty quickly. Using absolute risks often are much more transparent than relative risks. So this is a typical advertisement you may see, people using relative risks a lot. It sounds really great. This statin can reduce your risk of stroke by 39 to 60%. Sign me up. But if you actually look at the actual data on a population level, the absolute risk reduction is really potentially only 1%. In this particular study published in The Lancet, sure, there was a 50% risk reduction, but on an absolute level, it went from 2.5% to 1.5%, which may make a big difference on a population level, but for an individual patient, it's much more transparent to use absolute risk. This is one of my favorite studies looking at risk presentation, where they actually compared relative risk reduction, number needed to treat, and absolute risk reduction when they submitted a grant proposal. And they only varied the presentation of risk in the grant proposal about a cardiac rehab program and a mammography screening program. And the bars are the scores they got on a scale from 0 to 100, depending on the format that they used. So they were much more likely to get support for their proposal if they used relative risk. So I don't know how many of you write grants, but takeaway tip, but not necessarily as transparent for patients when they're in the room. And the worst thing we can do is use mismatched outcomes, where we present relative risks for benefits and absolute risk for harms. But unfortunately, this is what people often do when they're publishing their papers. Look at this great treatment that I've developed or I've tested. The relative risk reduction looks great. The absolute risks are often used to describe the harms. This was a study that looked at how that risk was presented in the BMJ, JAMA, and the Lancet over the course of 2 years. And 1 out of 3 cases did this. And not surprisingly, the media almost always does that because it sounds really great. So just be careful about that when you're talking to your patients, so that they don't come in thinking they're having this watershed treatment, breakthrough treatment with minimal harms and side effects. Oh, I'm not going to get that. It sounded really minimal. And consider that less can be more. So people don't all necessarily want to know all of the details, even if they want some information enough to make a decision. So here's an example from one of our studies as well, where a clinician was describing to the patient that her tumor was moderately differentiated and talked about the nuclear grade. And the information wound up really hindering her decision-making because she was really fixated on this one detail and was so confused by it and asked all these questions and even asked me after the visit, what did they mean by this? But what was most important was really the size of her tumor, whether it was confined to one breast, whether it had spread, and she kind of missed all of that information because she was fixated on this one bit of information that may or may not have been as relevant for her treatment decision. It was definitely less relevant than the size. The next 2 steps are eliciting patient preferences and values and agreeing on a next plan for next steps. And Tony Bach is going to talk a bit about preferences and values when he talks about how to respond to emotion. But I just wanted to briefly mention that the pictograph information and the risk information, people often ask, well, what if I don't know this offhand? And how do I do this in a session? It doesn't all have to be done in the same session. There are lots of decision support interventions or decision aids that have been developed that can help. Some of them are more generic, where you can actually plug in the information as you learn it. Some of them are pre-developed for specific clinical contexts. So I've listed some resources there if you're interested in looking at some that have been developed. But I'll show you 2 examples of some that have been developed in breast cancer context that look very different. The first one is an option grid. These are taking off and becoming more and more popular, where they're aimed to be used during a consultation, where they just summarize frequently asked questions of different shared decision-making situations. This one is about lumpectomy versus a mastectomy for early-stage breast cancer. And it really simply goes through what the common concerns and questions people have, enough for them to be able to compare these options. And then they're supplemented with a conversation during the consultation. The same decision is also, there's also a decision aid about this that's much more detailed and could be used outside the consultation as follow-up information. Most patients will be going to the internet anyway, and these are great places to send people for evidence-based information that can actually help them walk through the decision. And I think although they have, people differ on some components of them, in general they're much better than people stumbling across a health blog that may or may not be relevant to their needs or condition. So if you can find these tools that have been developed, they're all developed. If they have a development process, you can see how they're developed in an evidence-based way with minimal bias, with publications and titles and descriptions of the people who developed them, so you know who's producing them, so it's not necessarily trying to guide people towards one or another, it's just giving information. And this one even has patient stories that people can hear what other people considered when they made the decision. They have some expert opinions and so forth. So I'm going to stop there, and we can take questions at the end.